Okay, it looks like it's top of the hour. Thank you everyone for joining us today for our webinar. Just a couple quick things before we get started. You can submit your questions via the questions panel throughout the webinar, and we'll save a little bit of time at the end to get to as many as we can. And your certificates will be available this Friday by logging into your account. Dr. Hoban, if you'd like to get started, go right ahead.
Thanks. So thanks so much for joining today, guys. I think people are joining from kind of all over, so hopefully we have some time for some good discussion at the end as well. So I've been asked to talk today about colostrum, which is actually, I think, a really cool and unique topic. So I'm hoping that you guys learn a lot today. So I won't be discussing any specific devices or any products. So today we're going to talk about colostrum, about kind of how it varies very much from regular milk. We're going to discuss the unique nutritional as well as the non-nutritional components of what people call liquid gold. Or importantly, from a clinical standpoint, to share why all babies should get colostrum and what specific evidence is in special populations like preterm infants. And then we're going to learn about the logistics. So how do we collect and store colostrum, in some cases prenatally or postnatally. So what is colostrum? So colostrum really isn't milk. It's a species-specific, dyad-specific biologic fluid that really is very different from mature human milk. It is, though, a first food, but it's really a transition to go from intrauterine life with amniotic fluid to extrauterine life and breast milk. And then finally, and probably most importantly, it's an immune booster, really the first vaccine for babies well before they can actually get vaccinated. So in utero, amniotic fluid continuously bathes both the outside of the baby as well as the inside. They're continuously swallowing amniotic fluid, and the oropharynx and gut are bathed in the fluid throughout pregnancy. Now, this amniotic fluid isn't just liquid, it's full of bioactives. And these do a whole bunch of different things, but especially help with gut differentiation. So they help with intestinal growth and differentiation with various growth factors like epidermal growth factor, which I'll get into a bit more later. It also functions to help protect the baby from this foreign body within the mother. And it's a source of immune regulation with both regulatory and anti-inflammatory cytokines. And interestingly, the really same factors that protect the baby and the amniotic fluid are also found in colostrum, allowing this seamless transition from inside to outside, which I think is super cool. There's actually been some animal studies in which they feed animals after birth with amniotic fluid. Now, clearly this isn't logistically possible in humans, but from a kind of a biologic modeling standpoint, it's really interesting because they found that animals that were fed amniotic fluid prior to artificial feeding showed similar reductions in necrotizing enterocolitis, or NEC, so a serious gut problem, as when they were fed colostrum, suggesting they're really relatively interchangeable biologic fluids. Animals fed amniotic fluid showed a reduced colonic bacteria load and really showed downregulation of lots of scary inflammatory markers. So when is colostrum actually produced? So amazingly, colostrum is started to be produced by the breast as early as 12 weeks. So during those first stages of lactogenesis 1, you really have a little bit of buildup of colostrum. Most moms have some colostrum in the breast by about 18 weeks. And sometimes they'll leak, for example, after a shower. Postpartum, typically colostrum is only expressed in the first few days. We typically say about the first 3 days or so in the term population is colostrum, which can last a little bit longer in the preterm, or about 5 days. But there's not a kind of hard and fast finish. It's really this continuum between colostrum, transitional milk, and then finally mature milk. So I'm going to focus a little bit about colostrum as a nutritional product. So as we said before, colostrum is very different than mature milk. It's really low fat and low energy, and it's low in lactose. And lactose is the main sugar in mature milk. The fat content, especially in term colostrum, is much, much different than mature milk. And preterm versus term colostrum is also very different. Preterm colostrum has more fat than term colostrum. But because it's so low fat and low energy, in this nice review paper from 2013 by Ballard, which really talks about all kinds of different nutritional functions of human milk, she indicates that the primary function of colostrum really has to be immunologic and trophic rather than nutritional, since it doesn't actually pack a lot of bang for its buck from a nutritional standpoint. It's that interesting color, that rich golden color, because it's full of vitamins. So it's high in beta carotene or carotenoids, which gives it that yellowness. And this, along with vitamin A, copper, and zinc, is really a lovely booster for the skin, eyes, brain, and immune system. And it also has magnesium for heart and bone health. So it's really kind of one of those little vitamin shots that you can get at the convenience store, only obviously way better. So even though it's low in fat and sugars, it's actually really high in protein. Colostrum contains about twice as much protein as mature milk. And preterm colostrum is even higher in protein. You can see from this graphic on the screen here, the gray line is preterm. I don't know if you can see my cursor, probably not. The gray line is preterm and the black line is term. And you can see that in those first couple of days, when you have colostrum, the grams per ml of protein is incredibly high, and then it falls over like the first week or so. But preterm remains higher than term. This difference between preterm and term is important, though, because in our very premature babies, we often feed them donor milk in the first day or two of life if moms don't have enough colostrum to feed the baby, which we don't expect them to from a volume standpoint. But this is important because usually donor milk is from both term mothers as well as mothers who delivered many months ago. And so you can see from this graphic that that milk is really low in protein. And then it's been processed and pasteurized and frozen. And so that donor milk product that we're giving babies in the first couple of days is incredibly different in many ways, but especially from a protein load standpoint. So it's really not at all the same product. So it would be ideal to prioritize maternal colostrum. And I do point out I'm using the words maternal and mom and mother's milk. I do realize these are gender terms. They are more commonly used still in the literature, so I'm using them in my talk today. But it's obviously important with your own patients to determine what terms they feel most comfortable with, just to put that out there. So in addition to high protein, colostrum is also really salty. This is convenient for us as neonatologists because our preterm babies especially, their kidneys don't function very well and they tend to lose a lot of salt in the urine. So colostrum is a nice way to give them back a little bit of salt. Now, by definition, colostrum is high in sodium because when we move to transitional milk, that biologic change in sodium levels actually reflects the closure of mammary gland tight junctions. So those of you who have heard me talk about done other milk talks about how to produce milk early on and how to help moms with lactation success, they've heard me talk about the closure of these glands that signal secretory activation. And secretory activation or lactogenesis 2 occurs through milk comes in. So when you have that kind of moment of milk coming in, that signals that the cellular junctions are closed. And basically that really affects the sodium levels that have previously been moving through those junctions. So mature milk is much lower in sodium. So to talk about the immunologic component is probably the most important because we really think, again, that's why colostrum exists. Like amniotic fluid, it's full of these growth factors. So epidermal growth factor, EGF, specifically functions in intestinal development and repair. So as a neonatologist, this is important for me because a lot of my preterm babies have significant problems with their gut, either from necrotizing enterocolitis or just general problems with absorption or how their gut functions from a motility standpoint. EGF is resistant to digestive enzymes, so it doesn't get digested in the stomach and moves nicely all the way through the GI tract, allowing it to function throughout the gut. It's anti-inflammatory and prevents gut cells from dying and increases cell division, so it helps kind of heal unhappy cells. And it stimulates protein synthesis and glucose and water absorption, so it helps the enterocytes work better. And like I mentioned, it assists with damage repair. Now, amniotic fluid and colostrum have similar levels. And colostrum has about 2,000 times more EGF than mature milk. So it's literally just this lovely therapy for a sick gut. And nicely, it's higher in preterm milk. So the very babies who need it get the most. Another growth factor is TGF-beta. So along with insulin-like growth factor, we see really high levels in colostrum. Now, these as well assist with gut and tissue repair after stress. And birth, by definition, is stressful for a baby, but again, especially in the preterm delivery babies. TGF does other cool things. So it regulates cellular homeostasis and inflammation, and it can stimulate secretory IgA, which we will talk about later. That'll be important. And in a relatively recent study in Poland, they actually looked at this growth factor in colostrum. They measured it on day 3 in the term moms, and then a bit later in the preterm moms. Again, since preterm moms tend to have delays in their lactogenesis too, so they make colostrum for longer. They found that TGF-beta was actually, interestingly, a lot higher after mothers delivered via cesarean section. And it was a bit higher, although it wasn't statistically significant in the preterm population. So they concluded that colostrum feeding, especially after C-section, may prevent the negative impact of pathogens which often colonize the GI tract when you're not exposed to vaginal delivery. And we've all heard a lot about the different microbiomes that develop with vaginal deliveries versus C-section, and this TGF-beta in colostrum might be a way to mitigate that difference. This is just a nice graphic that shows the differences in some of these growth factors in in colostrum versus mature milk. So all the black bars are colostrum in various populations. So T is term, PT is preterm, kind of your moderate preterm, and then the very preterm. You can see in all of the populations, the black bars for colostrum are a lot higher versus mature milk, and they're especially higher in that moderately preterm population. So we talked about growth factors, but there's also a lot of other immunological properties of colostrum. So with those growth factors, they also regulate immune cell function. They promote GI tolerance to antigens and microbes because that's really the first window that a lot of bugs have to get into baby. So it's important to make sure we're not responding to everything. And colostrum also contains high levels of IgA, which remember we mentioned briefly before. But secretory IgA coats the gut. It forms this nice lining that directly blocks microbial adhesion. It also binds directly to microbes to inactivate them and helps cells enhance phagocytosis, so helps cells kind of eat up the bad players, and promotes good bacterial colonization or a normal healthy microbiome. You can again see that in this black bar in this graphic, it's a lot higher in colostrum versus in mature milk, which is the white bars. And finally, colostrum contains a lot of cytokines. So Zambruni in 2018 did a large study in mothers in Lima, Peru, actually, and found very high levels of cytokines in colostrum compared to mature milk. And finally, colostrum has live stem cells. So stem cells from multiple maternal cell lines are found both in colostrum and mature milk. We don't really know why they're there, but there's a potential for assistance in repair and damage, such as in neonatal brain injury. And some of you might know that I recently completed a study in which we gave fresh colostrum and mature milk into the noses of premature infants with intraventricular hemorrhage to see if it could potentially assist in damage repair. Importantly, stem cells are live cells, so they only survive for a couple hours. Therefore, if your colostrum is refrigerated or frozen, which is sometimes necessary, but in those situations, it won't contain live stem cells. So ideally is to have colostrum that then goes directly into the baby, whether that's directly from the breast or if you're pumping very soon afterwards. So you can take advantage of some of these stem cells as well as the bioactives that are modified potentially with time. So we've talked about why colostrum is so amazing from a nutritional, non-nutritional standpoint, But why exactly is this important from a practical standpoint? What kind of clinical changes do we see with colostrum? So we've talked about how it contains all kinds of cool stuff, over 90 bioactives, and these really function as an immunization or an overall protection scheme for babies who really don't have access to immunization for at least a couple months. It's a continuation of these transplacentally acquired protective factors, which are often given in the last few weeks of pregnancy. And all of this protection is especially important in settings with GI-acquired pathogens. IgA member kind of coats the gut as a protective layer. And this is really important in places like the NICU, where despite our best efforts, we know a really kind of abnormal microbiome gets set up within the baby. It helps establish a healthy gut microbiome. And the unique thing is that it's completely different with every baby. So every mother-infant diet has their own colostrum, and it varies with gestational age. So preterm colostrum is going to be different than term colostrum because it's kind of modified for the baby in real time. We've talked about how preterm colostrum is conveniently higher in most protective factors. The mother's body knows that she has to protect her vulnerable baby. And that's important because those last few weeks of pregnancy, when they usually get a lot of their antibodies, are missed in the very preterm population. So again, it's like a liquid super gold, especially for our most vulnerable babies. So now I'll switch briefly to talking about those vulnerable patients. So my specialty in neonatology, we typically focus on the preterm baby, and we know they often can't feed by mouth for a variety of reasons, whether it's simple immaturity or whether they're on respiratory support like CPAP. Now, when babies are still inside mom, the oropharynx is exposed continuously, as we said, to these bioactives and amniotic fluid. But unfortunately, in the NICU, the oropharynx is bypassed with tube feedings for weeks or even months in some cases. And if we do start NG feeds in the first day or two, we're often using previously frozen pasteurized donor milk, which lacks many of the benefits of parents' milk, both nutritionally and immunologically, especially differing from fresh colostrum. And importantly, immunoactives and growth factors act where they're supposed to be. So babies are theoretically, if they're at term, supposed to be fed at breast. And so breast milk has special factors that are supposed to work in the baby's mouth. And these differ from gut or more distal mediated intestinal absorption. There's special lymphoid tissue that's in the oropharynx. And we think that contact with the bioactives in breast milk actually promotes immunocompetence and immunomodulation of these specialized cells. So the breast milk has to get to these cells in the mouth. So it's ideal to have direct mucosal exposure and absorption of these factors, and they can then interfere with the bacterial colonization of the mouth. And again, this is kind of the first way that bugs can get in. And it's really important in our NICU where we have tubes and lines and all kinds of foreign bodies in the baby's mouth where we have this really abnormal dysbiosis. We talked before about secretory IgA, and we think that in addition to just coating the gut, it also provides a specific immune protection to preterm babies. So it stimulates B cells, which are white blood cells that help with the immune system. But we also think it's actually directly absorbed to increase immunity indirectly. And you can actually find secretory IgA in both the urine and the stool of breastfed infants, suggesting that they're actually absorbing it from the mother and taking it into the body. In a study of American very low birth weight infants, they randomized babies to fresh colostrum with oral immune therapy, which we'll talk about in a bit, versus sterile water on days 2 to 7. And they found that in the babies who got fresh colostrum, they could measure their salivary secretory IgA levels they were much higher on day 7, again, showing that they were actually absorbing the secretory IgA. They didn't show difference in actual outcomes, but it was a tiny study, 30 moms, so it wasn't powered. But they didn't start until day 2, so ideally, potentially, we could have even started this from the day of delivery, and potentially would have shown more benefit. So in talking about oral immune therapy, that study kind of briefly used colostrum and then measured secretory IgA, but I'll talk a bit more about overall evidence for OIT, or oral immune therapy, or sub-NICUs might call it mouth care with colostrum. There's various names for it. There's really no standard protocol specifically. It really depends on the unit or the research study. But basically, OIT is small amounts of fresh colostrum that are kind of painted into the baby's mouth with an oral syringe, a swab, a sponge, every couple hours when colostrum is available. And this can continue even once colostrum has transitioned to transitional or to mature milk. There was a Cochrane review in 2018, and they were looking to see whether OIT in this high-risk, very preterm population could prevent mortality, NEC or necrotising enterocolitis, or late onset sepsis. Now, at that time, they only found 6 studies, not very small or not very large studies at all. And so they said this was really very low quality evidence, unfortunately. They didn't find any difference in mortality, NEC, or late onset sepsis, but they did show that babies got to full feeds about 2.5 days faster, which can be clinically important. Now, because there's been so much interest in OIT and because it's become pretty standard practice, another meta-analysis was done 2 years ago with these same outcomes as that previous 2018 review. Now, even in just the 2 years from the Cochrane, they found basically double the amount of babies because they had multiple other studies. Now, with this larger number of babies, they found trends towards reduction in all of the outcomes. So mortality, NEC, and sepsis were all non-statistically significantly lower in the intervention groups. They also, though, showed a shorter time to full feeds and a shorter length of stay of about 10 days, which from a medical resource standpoint, as well as a family standpoint, is massive, like having your baby go home a week and a half earlier. And to do this with an intervention that's well tolerated and basically free. It's like the lowest tech possible thing we could do in the NICU is to put a few drops of milk in a baby's mouth. Because of this great safety profile and this significant potential for benefit, it's therefore recommended as routine care for preterm infants in the NICU. There's been one study that wasn't part of any of these reviews because it just came out last year. And this is a massive study in that it's really a third, again, of the number of babies from all these other studies combined. So it's a single large center in China of very low birth weight infants, and they randomized baby to fresh colostrum or normal saline, OIT, for a relatively large amount, 0.4 mLs, for 10 days. So they actually did find reductions across the board. So significant improvements in NEC, in late onset, as well as culture positive sepsis, and interestingly enough, severe interventricular hemorrhage. Like previous studies, they also found a faster time to achievement of full feeds. So this is only a single center, but it was since it's a single center, it's a relatively homogeneous population, so seems like good data. So very promising, again, that this really easy intervention could result in all of these significant improvements. So we know all the components of colostrum. We know why we think it's good. So then how do we get it? So how much colostrum actually is there? How much do moms make? So most moms don't know the answer because hopefully they're exclusively feeding at breast. But there was a nice study was done quite a while ago, but it was test weights of over 300 breastfeeds in the first couple of days of life in 90 exclusively breastfed term infants. So they found that moms made about 15 mLs in the whole first, or babies ingested about 15 mLs in the first 24 hours. So an average of 1.5 milliliters for every feed. This is really important, I think, to share with families. Because especially the fact that babies do okay with these small volumes. This is what nature intended. And if you're a healthy term baby, you're born with enough reserves on board that this is enough. It's literally like not even a teaspoon per feed. And the reason this is important is that when we give babies artificial feedings unnecessarily, we're usually giving them these big ready to feed bottles that have a massive, much more milk in them than this 1.5 mLs. So we're giving them way more volume than they need or that nature intended. So important to reassure moms that, again, they make a tiny amount of colostrum, but it's really quality over quantity. In this study, they also looked at mode of delivery, so C-section versus vaginal, or previous breastfeeding experience, and moms really made the same amount no matter what. There is a large variation in volume, and some of this appears to be because a lot of these studies are of moms who are either hand expressing or pumping colostrum, as opposed to that previous study of the breastfeeding population. In a recent review of 4 studies of expressed colostrum, they found a pretty wide range, so from 0 to 28 mLs in the first day, and half an ml to 99 mLs in the second day. So a very wide range. And I'll talk about the study that had both of those kind of high-end ranges in a moment. In addition to reviewing 4 studies, they also did their own study in this 2022 paper. This was in Japan, and the majority of moms were preterm delivery. So these moms were only told to hand express, and we'll get to that in a moment, but they hand expressed every 3 hours. And this graphic shows literally every single hand expression session from 0 to 48 hours. You can see that with the first expression or 2, they got a slightly larger amount, usually only an ml or 2. And that was probably the colostrum that had kind of collected in the breast during pregnancy. And then they get very little, almost nothing, until after the first 24 hours of life. The first 24 hours, they had an average of 2.8 mLs total. So a lot, even less than that, the term breastfeeding moms from the slide prior. In the next 24 hours, they had an average of 10 mLs. And they also found no difference by delivery mode or in this case, by gestational age. But they did find that volumes increased faster in moms who had previously delivered and in moms who started expression within 3 hours. And this speaks to just the overall importance of stimulating the breast within the first few hours of life if you're not directly breastfeeding, similar to some of those studies by Leslie Parker's group that showed that pumping within the first 6 hours is really associated with long-term lactation success. So how should we collect colostrum if we're not directly breastfeeding? So there's been multiple papers about hand expression or about pumping. This was an interesting study in which it was a crossover study in which moms pumped and then hand expressed and then pumped and then hand expressed. And it had some mixed results, but moms did report in this study at least that pumping was more comfortable. And in other studies that have directly compared hand expression versus electric pumping, of which there are not very many, it shows by far that electric pumping is superior. Those who have heard me talking before about breast programming know that I feel strongly about this data, and I'll share this study again, which I've talked about in other talks. This is by Lucier, and this was a lovely study in which they randomized mothers of preterm infants to either hand expression or electric pumping. After the first week, those who were in the hand expression group then switched over to electric pumping. But you can see both from the table as well as from the graphic that moms who were randomized to hand expression made much less milk in the first 3 days. So for instance, on day 2, an average of 0.25 mLs versus 14 mLs in the moms who were double electric pumping. So this is both statistically, but also clinically a huge difference. You can see in the graphic that the white bars are the electric pumping. And you can see from the beginning, there's a big delta between electric pumping and hand expression. And in this study, even though it's not shown here, all the way up to day 28, even when moms switched to electric pumping after a week, they never caught up to the moms who started off with electric pumping. So we're really setting our moms up for both short and long-term success when we're having them pump from the beginning. This difference between hand expression and pumping is similar to a 2007 study done in sub-Saharan Africa, which showed that by day 2, the moms in the double electric pump category were already making more milk and continue to do so by day 7 compared to hand expression. So a lot of some LCs or moms or nurses will say, well, the pump doesn't really get out this really thick, sticky colostrum, and so that's why we tell moms to hand express. Well, this study did both. So this was a relatively small study of American moms who delivered quite preterm. So they advised mothers to double electric pump followed by hand expression after each pumping for 3 days. And then after 3 days, they switched to hands-on pumping, so pumping with some massage. And again, this kind of addresses that concern that the pump can't always remove that really thick, sticky colostrum. So this was the study. I had said a few slides ago that there's one study in which the very far end of these ranges came from. That was this study. Again, a single study, but these moms made a lot of colostrum. You can see the range was up to 125 mLs the first day, but an average of 28 mLs, so like way more than all the other studies. And an average of 99 mLs on the second day. Again, a really big range. And so again, it's only a single study, but this adds to the literature that electric pumping really seems to bring out a lot more colostrum than hand expression. And so why is this important? So as we talked about, it not only sets moms up to get more colostrum initially, but it really programs the breast best for long-term lactation when you're electric pumping from the beginning. In my opinion, hand expression really is not adequate to establish a milk supply and really shouldn't be used alone in at-risk pump-dependent mothers. And there's a significant physiological basis for this, in that when babies breastfeed, they use mostly suction, but as well as compression, either from the mom actually holding her breast or massaging it, or the infant doing it. This releases prolactin and oxytocin, but prolactin is really where the money is early on in lactation. We know that prolactin helps close those tight junctions. Remember when sodium is dropping and when sodium is low, the junctions are closed and your milk comes in? That's helped and facilitated by prolactin. So you need prolactin to close those tight junctions. But prolactin also helps you make more lactocytes, and it prevents apoptosis of lactocytes. So through a variety of different ways, prolactin makes more milk. Now, an electric pump has suction but not compression. Hand expression has compression but not suction. But only suction makes prolactin. So if you're just hand expressing in those first couple of days, you're not getting these big prolactin surges. And we know this from studies that you just don't get that surge with hand expression. If you don't get that surge, you're not going to be able to facilitate tight junction closure and make more milk. So it's really vital that we're having moms who cannot feed at breast use an electric pump from the beginning. So we have our colostrum, we've gotten it out. Now what do we do with it? So because of all those bioactives and other amazing goodies in there, like stem cells, the best thing is fresh. So either directly from the breast, or if you are pumping or expressing, to store in small bottles that you can hopefully immediately give at least some to the baby. It's important not to mix pumping sessions. So if you already have some in the fridge, don't add more to it. Put them in small little containers so they can be used individually. Many NICUs have colostrum kits, so we have like small oral syringe kits with little tops that moms can have ready to go. And you should be using fresh colostrum or any fresh milk within a few hours. If it's not going to be used quickly, it should be put in the fridge, or if moms have a large amount that's not going to be used quickly, it should be frozen. When we're doing this for OIT, if many units will just use the oral syringe directly, but if you are using swabs, I really recommend to not use a cotton swab. I know some of the pictures show that, like a Q-tip type swab, but it really tends to absorb all the milk. Like Q-tips are supposed to absorb liquid. We don't want them to absorb liquid. We want the liquid to go into the baby's mouth. So if you're going to use a swab, to use more of like a sponge kind of product that's specifically non-absorbent. So I'm going to move briefly to the concept of prenatal colostrum expression. And this is something that's really gained a lot of traction lately. Maybe a good thing, we're not really sure, but because it's become quite common, I wanted to bring it up. So in a separate note, not with expression, but just passively, some moms will notice colostrum leaking throughout the second or third trimester, especially after a hot shower, for example. So there are some moms that if their breasts always leak after a shower, for example, will passively collect the dripping milk from their nipple into a sterile container like is shown. You should never actively try to express colostrum before at least 36 to 37 weeks because nipple stimulation can facilitate preterm labor. And all moms, if they're thinking about active expression, even after 36, 37 weeks, really should talk to their doctor or obstetrician before starting because there are some definite contraindications, both from a maternal and an infant standpoint. This has become somewhat common, again, in some places, particularly in Australia and the UK, but it's gained traction in other pockets as well. With healthy moms who want to have a stash of milk immediately available postpartum to prevent formula use or artificial feeding. And this is important because we do know that even a single formula feed in hospital does change the microbiome for the baby. So if moms choose to do this, and if it's been cleared by their doctor, they can hand express into a clean cup or a container 2 to 3 times a day. You can buy kits online to do this, and then store in the freezer to bring to the delivery hospital. Now make sure it's labeled, and before mom brings it, she really needs to make sure there's somewhere to put it because this isn't necessarily a common thing, especially in many places. And so you won't necessarily have access to a freezer to keep it frozen. So what we don't want to do is mom to do this and then for it to go bad. If it does thaw, it has to be stored in the fridge and used within 24 hours. And to make sure, again, that the mom is talking to her healthcare provider about this. We had a case, since this is not common practice in Ontario, we had a case a few months ago where a mom had been passively leaking for many weeks and delivered at about 32 weeks. She brought in all her colostrum that she'd been passively collecting throughout the few weeks, but because the baby was a newborn and they weren't labeled, the bedside nurse assumed they must have been for someone else because the mom had just delivered. How could she have all this milk? And it was discarded, which was horrifying to me as the director of breastfeeding medicine, and I had to deal with that with the family. But it's important to label it and talk to your healthcare provider that you have this milk available. These are some examples online of instructions for moms or collection kits that are given out prenatally by hospitals or ones you can buy online. These are all various kind of Canadian products and websites, but these are available throughout the world. So we know this is happening, but is there actually any evidence for antenatal expression? So the only Cochrane that was done was quite a while ago, 8 years ago, and really said that we have, unfortunately, no high quality evidence to inform safety and efficacy. There was a more recent scoping review just last year, and they found 20 studies. But many of these were kind of feasibility, small case series kind of studies, and only included one RCT, which I'll talk about in a second. Of these 20 studies of antenatal expression, most of them focused on a high-risk population, particularly diabetes, but they had very mixed protocols about how often, how much, when to start, and therefore the authors felt they couldn't really pool the outcomes as they were either very heterogeneous or were very vague outcomes like lactation performance, which I don't know what that means. So they basically said we need more evidence. So the only RCT we have for antenatal colostrum expression is specific to moms with diabetes. So we know physiologically that moms with diabetes are at risk for delayed lactogenesis 2 or for their milk coming in. In addition, their babies are at risk of hypoglycemia. And if you don't have breast milk to try to treat hypoglycemia, these babies will require formula or glucose gel and or NICU admission for IV fluids. So in 2017, they did a very large RCT in Australia. This was of over 600 pregnant women who had either gestational or pre-existing diabetes. Now, importantly, these were only low-risk moms. So we talked about how there were some contraindications to antenatal expression. There are quite a few, because since it can facilitate preterm labor, they excluded women that were breached, if the baby had macrosomia or growth restriction. So any concerns about any delivery concerns or concern with the baby's blood flow, any fetal anomalies, or any other uterine concerns. So placenta previa, a history of a classical section that could put you at risk for uterine rupture with labor, or any antepartum hemorrhage. So these were only moms that were very low risk, and that's really critical. They were randomized to twice daily hand expression for colostrum versus not expressing, and they started at 36 weeks. So the first important outcome was safety. So will this actually bring about more moms delivering at 36 and 37 weeks, which even though you're close to term, as a neonatologist, I know that this is not term and these babies still can have issues. So importantly, they found no difference in age at delivery. Now for their outcomes, they were looking to see whether will this help prevent NICU admission for baby for hypoglycemia or decrease length of stay. So unfortunately, they didn't show that. But what they did find is that the moms who antenatally expressed did have higher rates of exclusive breast milk in the first 24 hours in hospital. And they also had higher rates of exclusive breast milk feeding until infant discharge, or for the first 7 days in hospital if that was longer. And this is important because we know that exclusivity during hospitalization is strongly correlated with both continued exclusivity as long as lactation duration in general. So even though they didn't really see what they hoped to see, which was a decrease in NICU admissions, they did show it was safe, and that potentially, again, helped with exclusivity, which can then help with duration, which can help with overall breast milk dose for the baby, which we know improves outcomes. So antenatal expression then appears safe in healthy, low-risk, term-motivated mothers, so a very specific population. Ideally, probably is for babies who are at risk of hypoglycemia or moms at risk of a low initial milk supply. But it really should never be done preterm and shouldn't be done in moms or fetuses with any risk factors. We really need more good quality evidence about whether it actually changes outcomes. Does it decrease infant hypoglycemia or need for formula supplementation or NICU admission? And does it, other than outside this single RCT, does it improve lactation outcomes? Does it help with lactogenesis 2 timing? So does your milk come in earlier if you've been expressing for a week or two prenatally? And does it affect long-term duration of lactation? So still, I think we need quite a bit more evidence. So in conclusion, colostrum is a nutritional superfood. It's full of proteins and vitamins, and it's unique for every baby. But we think its most important role is really as a first vaccine. It has an incredible amount of biologics and immunological and anti-infective properties, which is especially valuable in those preterm babies who didn't get that last trimester of transplacental protection and are in the NICU. OIT with fresh colostrums appears to reduce the time to full feeds and length of stay, which is important for families as well as for society. And it potentially can protect against serious morbidities like necrotizing enterocolitis. I really recommend using a pump followed by manual expression if needed for moms who are unable to feed colostrum at breast. And finally, prenatal colostrum expression in the low-risk term population may have benefit, especially in certain groups, but we really need more data. And I am happy to take any questions.
Great. Thank you for that great presentation, Dr. Hoban. It looks like we've got about 15 minutes for questions, and they are rolling in as you're talking. They're stacking up, so we'll jump right in. The first question that came in is, Is it safe to pump and store colostrum during pregnancy beginning at 38 weeks?
So I'm assuming that the question probably came in before I did those last couple slides.
It did.
So yes, it does appear, again, with the caveat that it has to be a low risk population, but yes.
Okay, thank you. The next question is, mom who uses a manual breast pump to collect colostrum the first 48 hours, would they get the same results that a mom pumping with an electric breast pump does?
So I'm assuming by a manual pump, you're talking about they're talking about the ones that have like the handle, as opposed to like a Haka pump, which is just kind of an indirect means of emptying the breast. As long as you have suction, which even a manual pump does have suction, you do get a prolactin surge. That being said, when you actually measure the amount of prolactin surge with a manual pump versus a double electric pump, you get a lot more bang for your buck with a double electric pump specifically. So even though a manual pump, it is better than hand expression if that's all the mom has. But like when you actually look at the evidence, a double electric pump is the best, both from a prolactin surge and from a milk volume standpoint in multiple studies.
Okay, thank you for that. The next question is, how long should they pump before switching to hand expression?
We typically would have moms pump for like 20 minutes. If they are for some reason making milk for that long, they can continue to pump a bit longer. But we would typically do the normal amount of pumping time and then only do kind of hand expression at the end, particularly from kind of the axillary area to try to get the colostrum out.
Okay, thank you. The next question is, so most of the data you are showing for electric pumping early on for colostrum is for preterm babies. Is this still the recommendation for term babies as well, who may not be able to breastfeed directly as well? And in term infants, does this pumping potentially set the lactating person up for an oversupply?
So those are good questions. So it's true that a lot of the data for pump dependency, or almost all of it, is for the preterm population. But physiologically, it's true no matter what the gestation is. So if your baby isn't able to effectively empty the breast, whether that's for maternal, the parent chooses not to feed directly at breast, or the baby cannot effectively empty the breast, say they're late preterm or they're in NICU for some other reason. No matter what their gestational age is, it's important to use a pump initially to get that prolactin surge. So then if the baby can feed at breast in the next couple of days, you've already kind of set the groundwork there for having a good supply. It shouldn't, if your baby isn't feeding at breast, it shouldn't set you up for oversupply. It should kind of just get you where you should be if the baby had been directly feeding. And we know that compared to babies directly feeding at breast, even the term moms who are pump dependent do tend to make less milk. As good as pumps are, they're simply not as good as a human baby. So it shouldn't make you like start making gallons and gallons of milk. It should just kind of put you on par for where you could be if the baby was feeding at breast.
Perfect, thank you. The next question is, why can't colostrum expressions be combined, especially if they are collected within an hour or so of each other?
So typically, you'd never want to combine multiple sessions because then like if the milk is already in the fridge, for example, it's at different temperatures, and that can facilitate bacterial growth. Or if you're like opening and closing the container multiple times, it's just more potential exposure to microbes, as well as different temperatures of the milk. If you're in within, I don't know, a few minutes or something, you're at the same pumping session, you've already closed the bottle. It's probably okay, but I wouldn't mix pumping sessions from an hour or two apart because they are going to be different temperatures and just again more opportunity for contamination. Ideally, as soon as you're pumping, you're also giving it to the baby. So the best thing would be to give it to the baby and then have a new source of colostrum for the next kind of Q2 hour feed, because then you're getting all those lovely bioactives and stem cells.
Perfect, thank you. The next question is the output for hand expression versus pumping based on one or both breasts?
So the outputs in these studies are the two breasts combined. And you can single or double electric pump. There is data to suggest that double electric pumping gets you a bigger prolactin surge or gives you more milk volumes than single electric pumping. So single pumping in, back to back. It also saves time, obviously. So I always recommend double electric. But all these volumes, yes, are for combined breasts.
Thank you. The next question is, how much of the droplets of colostrum are being wasted using a pump? Or I'm sorry, let me repeat that. So much of the droplets of colostrum are wasted using a breast pump in the first days. It is easier to collect the small amount of colostrum when a mom hand expresses so that we can collect it in a spoon or smaller container. It makes sense starting day 3 once colostrum amount is a bit larger. How do you recommend collecting in the first 24 hours?
From a physiologic standpoint, we know that pumping within the first 6 hours of after delivery is very strongly associated with both short-term and long-term milk output. And so when you're starting to pump, you're doing it to get colostrum out, but you're also really doing it to program the breast to make milk for days to weeks to months. And we know that waiting to pump even a day can really decrease your long-term lactation success. So waiting to pump a few days to get colostrum out with hand expression can really affect, again, long-term lactation. So I think it's important to be able to do both, to be able to get that colostrum out, but also to really start with breast programming and get those prolactin surges. So trying to do a combination. I do appreciate you do lose some of that colostrum in the pump. Every once in a while, if mom has really low volume, sometimes they'll express first and then pump. So kind of do the opposite. But as long as you need to still be pumping to try to program the breast. So if you want to do it before, that can also work.
Okay, thank you. And to give a little plug on a product that's being launched, I believe next month, the colostrum container that we're working on should help alleviate some of that problem with losing some of the precious colostrum. So for more information about that, check with your sales rep. The next question is, and we have a lot of them with the next few minutes that we have left, how long is colostrum good for when frozen?
So similar to breast milk, you can store it up to 6 months. The sooner to use it, the better. But there are definitely moms who store it in the freezer, and then if like the baby gets a cold, for example, in the first few months, they'll use it as kind of a natural medicine. I don't think there's great evidence behind that, but it's definitely done by a lot of people. When you do freeze any milk, though, colostrum or otherwise, if you're going to be storing it for the long term, you really want to either invest in a good freezer, so a good deep freezer, or if you're having it in your kind of regular freezer, it should never be like in the door or close to the top, for example, where it's subject to like all the changes in temperature. You want it kind of very deep down because it's good, precious stuff.
Thank you for that answer. The next question is, does the mother's nutrition affect quality of the colostrum in breast milk?
That's a good question that we get asked all the time, particularly by mothers-in-laws who want to make sure the mom only eats certain things or something like that. Although the breast milk can vary somewhat by maternal diet, so particularly by things like fatty acids or DHA, for example. Like if the mom eats a lot of fish, she'll have a lot more DHA in her breast milk. For the most part, over a very wide range of dietary intakes, breast milk is remarkably similar, both throughout the world as well as by diet. So for the most part, just like in pregnancy, your baby will take whatever it needs, and the same for breastfeeding. Your breasts really are quite remarkable at making high quality milk, no matter how good quality your diet is. Obviously, it's ideal to take in a lot of calcium and to try to stay really well hydrated. But maternal diets, fortunately or unfortunately, doesn't actually affect breast milk to the extent that we would think it would.
Thank you for that. The next question is, what happens to the components of colostrum if a mom is tandem feeding until delivery?
That's an interesting question, and we definitely will definitely see moms who have breastfed throughout pregnancy. So when you deliver a new baby and you've been previously breastfeeding your toddler, for example, the breast milk does very quickly change after delivery. It doesn't completely change, so you will have less colostrum. I know that's not a word, but your colostrum won't be quite the same as it would have been if you weren't previously breastfeeding. But the milk does go from mature milk to more of a kind of transitional milk kind of pattern when you deliver a second child when you're already breastfeeding. So the body does know you've had a new baby, and it does change the milk, but it's not quite the same. But obviously the benefits of continuing to breastfeed your previous child are amazing. So we would never recommend weaning your first child so then you can give your second colostrum.
Thank you for that answer. The next question is cold or frozen colostrum better than none if unavailable to use fresh?
Definitely. Yeah, 100%. So colostrum or human milk is absolutely amazing. When it's frozen, it's definitely some of the bioactives and other substances are altered, but it's still way, way, way better than nothing. So fresh is amazing, but fresh is logistically challenging if you're a NICU mom. So refrigerated is next best, and then frozen is next best. But we will take whatever we can get in whatever form. And we know it all helps babies, and fresh can be very logistically challenging. So I don't mean to suggest that if you can't give colostrum and then within 2 seconds get into the baby's mouth, it's not worth it. Definitely not at all. We'll take anything. Frozen colostrum is also very good.
Okay, thank you for that. We have about 3 minutes left, so we'll try to get a couple more in before the webinar ends. The next one is, someone is still not understanding how prolactin is stimulated in pumping and not in hand expression. So maybe go over that explanation again.
Sure. So I don't know, it might be on the Medela website, but I've done other talks on lactation success or lactation physiology in this forum and others. And there's been a lot of really nice physiologic data that has measured both in human and animal models, but a lot of human models. They've measured serum prolactin levels in the moms with hand expression, with manual pumping, and with double electric pumping. And there's as well as direct breastfeeding. And double electric pumping, you get a very similar prolactin surge to direct breastfeeding. So especially in the first couple weeks of life, you get much bigger prolactin surges than later. And prolactin is most critical in those first couple weeks postpartum, again, when you're closing those tight junctions and stimulating the breast to make new lactocytes. Which isn't really possible later on. So you have this really time-limited window to program the breast with these prolactin surges, and you simply don't get a strong lactation surge with manual expression because you need that suction, basically suction of the nipple physiologically stimulates a prolactin surge. And so you really get an oxytocin surge with manual expression, and it removes the milk that's in the breast, but it's not at all as good at getting the prolactin surge and then making more milk.
Okay, thank you for that.
I encourage you to look at some of my other talks. I have many, many slides about this because I feel quite passionate about it.
Yes. And you do such a great job presenting this.
And I'm not suggesting that pumping is easy. I pumped for 2 years. I know it is really a really hard thing to ask parents to do. It's incredibly difficult. And I'm glad that my lived experience is able to tell me what I'm asking my families to do in the NICU. Pumping is not easy, but usually it's temporary. And it really does set you up to make informed choices, or to make choices later as far as what your lactation goals are when you have enough supply to make to decide on those goals, as opposed to your supply deciding for you.
And it's hard work, however, it's very rewarding work to give that breast milk to your baby and watch them grow and be healthy. So it surprisingly is the top of the hour already. Just a couple quick things before we end the call today. We want to thank everyone for joining us today for the webinar. This was great. An evaluation will pop up in a separate window once we close the webinar. So be sure to fill that out for us. And a couple quick things about the next few webinars. For those that are in Hawaii, we will be having a live event with Dr. Diane Spatz. It's a half-day event on October 18th. So if you are in Hawaii, you can
Then you're very
register.
lucky.
Yes, you can register at medilaeducation.com. And due to popular demand, we will actually be replaying our February webinar that was presented by Dr. Thomas Hale for our November 16th webinar. So registration for both of those, the webinar and the live event, are now open on medilaeducation.com. And again, Dr. Hoban, we just appreciate you and thank you for presenting for us today. And I wish
Thanks for
everyone a
having me.
great afternoon. Thank you.
Thanks, everyone.